Thank you for inviting me and allowing me to participate. My name is Rishi Balkissoon, and I am an adult reconstructive orthopedic surgeon at the University of Rochester in Rochester, New York. Today, I'll be discussing total hip arthroplasty complications, specifically focusing on dislocation following hip replacement surgery. If I can advance here. So dislocations in hip replacement surgery are easily among the leading cause of failure of hip replacements in the United States, requiring revision. And when we look at other studies throughout the world, we see similar numbers, which between aseptic loosening of implants and dislocation, these are among the leading causes of failure of hip replacement requiring revision surgery. And when considering the dislocating hip replacement, it's important to consider some of the reasons why hip replacements may dislocate. And I found this particular article useful in identifying some of the factors that we should be considering. Some of the factors that we should consider are patient factors. And I'll say, first of all, that it's not my intention ever to blame the patient first, but we should understand that patient factors are definitely should be considered as a part of the reason why patients may start dislocating. And certainly factors that are listed here are all potentially contributing factors. Cognitive problems such as dementia or neuromuscular disorders where there is just really either lack of muscular tone or irregularities in muscular tone should be considered. We know for some reason, not entirely clear, that an age greater than 80 is a risk factor for dislocating. I believe personally that might be related in some way to the loss of muscular tone over time. Alcohol abuse is a known risk factor, again, for not entirely clear reasons, perhaps just going to extremes of motion without realizing it as a consequence of alcoholism. Having prior hip surgery is a definite known risk factor, such as having proximal femoral osteotomies or any prior acetabular fracture fixation or any prior proximal femoral fixation. Things like that are all known risk factors, which probably as a consequence of trauma to the soft tissue envelope surrounding the joint may lead in part to dislocating hip replacements. Fractures as kind of going along with the prior hip surgery, any proximal femoral fracture. We often encounter, for example, femoral neck fractures treated with cannulated screws, intertrochanteric femur fractures treated with either a hip screw and plate versus some type of a cephalomedullary device or blade plate device. These types of surgeries may all predispose toward instability following hip replacement. Developmental dysplasia is definitely a known risk factor, in part probably because of the irregularities of proximal femoral and acetabular morphology. These things should be considered as certainly risk factors. And we know that this is one that contributes potentially. Osteonecrosis was listed as one. I can't tell you I know entirely why that might be the case, but this is something that we may need to check the reference on, but I will say that osteonecrosis was also listed. Inflammatory conditions, rheumatoid arthritis, for example, may ulcer some of the soft tissue envelope, and that may in part contribute to instability. We know that the integrity of the hip abductors, and specifically the greater trochanter in which they insert, is also potentially a contributing factor, such that if there is either trochanteric fracture or loss of abductor function somehow, this may become problematic for hip instability. And then prior spinal fusion or spinal pelvic irregularities, things like spinal scoliosis or degenerative disc disease, flat back syndrome. These are the types of things that we really need to consider as causes of dislocation on a patient end. And these factors alone should be considered as risk factors for dislocation even prior to contemplating hip replacement surgery, so that when we know we encounter patients with these factors, we may adjust our surgical strategy accordingly. of course, on our end, we really need to be considering surgical factors and how they may play a role in hip dislocation. So surgical approach has long been debated as a potential risk for hip replacement instability. And it's often said that posterior hip replacements are more likely to dislocate rather than anterior or anterolateral or even lateral based approaches. The reality, however, has not necessarily been demonstrated to um, to sort of pan out as a necessarily risk factor when considering various different elements, including some of the patient factors. Fundamentally, when looking at, there's a very nice study looking at over 30,000 hip replacements out of Canada, and you can see here the statement from that particular study clearly states that anterior surgical approach was actually associated with a higher risk for complications. Now, maybe this is related to the region in which that surgeries were being done, and other surgical factors such as surgeon learning curve. But in this particular study, it was said that there were higher complication rates, including dislocation, when performed from an anterior approach. So this is really still an unsettled matter, and we do know that capsular repair from a posterior surgical approach may lead to improved stability following hip replacement surgery. So I'm not one to believe yet that surgical approach is really a significant factor. And I think that there are many other factors that play a more important role in whether or not a hip replacement will begin to dislocate. Surgical factors also include impingement of tissues, and that includes bony impingement. I found a very nice current concepts review looking specifically at this concern. I'll say that this should also include soft tissue impingement, but what you can see here are examples of where a hip replacement can start dislocating. And I guess especially in the diagram, on the third diagram here, you can see there's some bony overgrowth or such as osteophyte formation that may lead to impingement of the femoral neck on that bony surface, and that may cause instability or dislocation in the opposite direction. And that can occur also with soft tissues present. But you can see that if there are any femoral irregularities, such as pre-surgical cam impingement, that may have led to some irregularities in the femoral morphology. That usually would be gone in the setting of a hip replacement after we perform femoral neck resection. We have to, of course, consider during surgery our positioning of implants, and this is something that is also long debated and not entirely decided on. But importantly, one of the more traditional studies that is routinely cited and is and still cited to this day, although was performed and I guess published in 1978, is this paper looking at approximately 300 hip replacement surgeries and that were dislocating and their reasons for dislocating, and trying to group them into a range of component positioning that may predispose a person toward dislocation, and identifying what those parameters might really be. That this really did only look specifically at the acetabular components, and is a limited study in many ways. But this is referred often today as still the Lewinick safe zone. I'll apologize for misspelling Lewinick in my text, but this looks at acetabular anteversion as 15 degrees plus or minus 10 degrees, and acetabular abduction or inclination as 40 plus or minus 10 degrees. And these are the typical and really historic range that we aim for. And I'll say that oftentimes we don't deviate very far from these parameters when we're performing modern day hip replacement, although there are certainly factors that may affect that. And again, as noted, this has routinely been called into question, including by this paper here in 2016, saying that the majority of hip replacements that are dislocating in this particular cohort were within the Lewinick safe zone for acetabular component positioning. So just important to realize that that was an early and historic look at where we should be positioning our implant, and certainly an important effort nonetheless. And despite the ongoing criticism of the study, including by myself, I'll say that we still aim for a lot of the similar parameters that are listed for the acetabular component positioning, although certainly may adjust our strategy according to what may be going on either with the patient's anatomy or patient's individual factors. Of course, we cannot not consider the femoral positioning. And when we look at the femoral side, we have to consider three major factors, including offset, how we may adjust the length of the limb through the femoral component, and how we may adjust component version of the femoral component. And these three things together, really, once we've established an acetabular center of rotation by placing an acetabular component, these three things together serve to effectively tension our soft tissues, which is really a critical feature of doing a hip replacement surgery and winding up with an acceptable outcome with hopefully minimal potential for hip instability. And what I mean by that is I often tell my own residents and trainees, as well as my patients, I think of the hip ball and socket joint as having essentially rubber bands holding the hip, the ball in its socket. And those rubber bands are really the surrounding musculature, including hip abductors, but also hip flexors, gluteus maximus, and other soft tissue attachments to the proximal femur, including the capsule. And the reason I point that out to my patients as well as trainees is that soft tissue tensioning is not something that's easy to judge or understand by using any type of imaging such as X-ray. We can't judge that by using MRI. I do believe we can help start judging that by pre-surgical examination. And there was even one study looking at patient flexibility as a risk factor for that I'm familiar with as a risk factor for instability. And what that study looked at is that if combined flexion, adduction, and internal rotation were summative of 115 degrees or more, that person was considered higher flexibility. And for that reason, additional strategies during surgery might be taken to adjust either component positioning or some other factors that we'll discuss shortly. But it's important to realize that soft tissue tensioning, if not appropriate, can also lead to hip instability and dislocation. And the analogy is that those rubber bands, if they're not nice and snug, can allow the hip to slide out of the socket. Whereas if the rubber bands are appropriately snug and tensioned appropriately, then we can allow the hip to be held into place. This is especially relevant also when counseling our patients on leg length inequalities, because in an especially flexible person, such as a patient that I took care of who had Ehlers-Danlos syndrome, this patient in particular, I had to counsel on the potential for leg length discrepancy. While a person is under anesthesia, it even further potentially exacerbates a person's connective tissue laxity. And that's important as well to consider, meaning if a person doesn't have great soft tissue tensioning because of their native connective tissue disorder, then that person may go on to have excessive lengthening of their leg deliberately in order to maintain stability of a hip. So these are things to consider with regard to component positioning. I will say that this is another very important consideration is head diameter. And you can see on the diagram on the right side that the femoral head diameter, if larger, has greater amount of excursion of the femoral neck prior to impinging on its acetabular component, and therefore allows for more freedom of motion and less likelihood of impingement prior to then dislocating. And then when you look at the diagram to the just beneath in figure 2B, taken from paper looking at this specific issue, you can see that if you shrink the size of the femoral neck, now you've improved the femoral head-neck ratio while maintaining the same size of the femoral head. And what that also does is allow for greater excursion of that femoral neck prior to impinging on the acetabular component, and therefore, again, more free, unrestricted motion, even with a smaller femoral head. So these are factors that we can adjust during surgery and important to consider. Certainly our choice of implant matters. There are dual mobility constructs. These are sort of gaining popularity in some ways, and in many other ways may also be losing some level of popularity. You can see in the bottom right-hand corner an example of that real-life image, but also on the left side, this is essentially a ball within a ball, and it's a smaller ball within a larger polyethylene ball that then articulates with the metal or acetabular component. The important thing to understand here is that there have been some variations to the European designs that are more similar to the one seen in figure A, whereas in figure B in the United States, and I'm not sure how this has changed throughout the world, there has been introduced another layer of modularity such that we can use screws into the acetabular component for better fixation. And we can also add a liner that is now yet another interface or point of modularity that in itself may potentially have problems that I will demonstrate later. But this is a way of increasing the effective femoral head size, but also having a ball within a ball, which, as the diagram on the bottom left shows, can allow for an additional 10 to 15 degrees of additional motion through the second articulation. And other factors that can be adjusted, including modularity of the femoral stem, where we can adjust femoral version through modularity. Of course, we can adjust offset, oftentimes using either standard or high offset implants, reduced offset implants, and those things can be adjusted to fine tune our soft tissue balancing. And then, of course, liner design is something that can be and should be considered. And with liners, they often, most companies will offer neutral liners, oblique liners, offset liners, lipped liners with a high wall type of a design, and even constrained liners, in addition to potentially dual mobility bearing. So the diagram depicted here really shows that where you place the position of a lip, which is can be used as a way of preventing instability, can also lead to impingement and potentially increase the risk for instability if we're not careful about how we position it. So just something to think about. So there are many different factors and implant choices that we can make during surgery that should help us determine whether a construct is stable. And then, of course, the soft tissue tensioning that we're performing on the operating room table, it really does matter. Other surgical factors we should consider on our end is how we consider and how we think about spinal pelvic irregularities and biomechanics. And what I would say here is that I kind of already briefly touched on this. I would encourage you to look at the diagrams and this particular primer, which really help understand some of the relevant parameters that we should be considering using lateral X-rays to include the lower lumbar spine, or at least the lower lumbar spine and entire pelvis, from either a standing or sitting or sitting position, and how that might change from one position to the next. And if we're lucky, we should also try to include the entire lumbar spine so that we can also get one additional parameter. But what you can see depicted here in these diagrams are SS equals sacral slope, PT equals pelvic tilt, PI equals pelvic incidence, and APP equals anterior pelvic plane. And these are all parameters that should be understood and how they relate to one another. And then on the right-hand diagram, this is looking at it as with change in the position of the from seated to standing, and it also looks at what we call the pelvic femoral angle, which is the position of an orientation of the pelvis as it relates to the proximal femur while seated. And then how the different parameters may change, including something called the acetabular index. And so these are all different parameters that should be looked at and studied when considering irregularities of the proximal, the spine as it relates to the pelvis. And they summarize in table format ways that can be that can help us decide maybe how we might change the orientation of our implants to maximize, or I should say instead minimize the potential for instability following hip replacement. And so you can see in 1A, there's a normal spine and spinal pelvic relationship as determined by what we call the pelvic incidence and difference from lumbar lordosis if lower than 10 degrees, or alternatively using what's considered the standing APP, which is the anterior pelvic plane, and essentially a measure of the tilt of the pelvis. And if these measures fall within the parameters outlined in the table, then that plus combined with the sacral slope of greater than 10 should indicate that that person has a normal and flexible spinal pelvic relationship. Whereas 1B, using those same numbers can lead you to understand that a person may be stuck standing. 2A, flexible and unbalanced, or otherwise referred to as flat back, and then 2B referred to as stuck sitting. And what you can see is when characterizing or classifying a spine and spinal pelvic relationship this way, on the right-hand side of the column, it can tell you some of the different targets we may aim for instead for our component positioning. And that really looks at acetabular anteversion specifically, and then combined version, which is the summative version of the acetabular anteversion and femoral anteversion. And with that, I won't say much more about that, but certainly worthy of not only knowing, but also just maybe studying and looking at some of these features as in terms of how they might help guide and minimize the potential for postoperative instability. Now, if a hip dislocates, it's important to understand, first of all, when we see a patient, of course, we'll see them in the emergency department or scenario. We should try to gauge, first of all, even using clinical examination, what is the directionality of dislocation? And that's really important because it'll help us decide whether or not, and how to reduce the hip. And so how we think about this is that if a hip is on the left-hand side, flexed and externally rotated with shortening, that may be more likely anteriorly dislocated, whereas on the right-hand side, you can see the patient is maybe flexed, internally rotated and shortened, and then posterior dislocated. And of course, it's not impossible to be almost directly laterally dislocated as well. But it's important to kind of use your clinical evaluation as a start. And then it's really critical that we get appropriate X-rays, especially as orthopedic providers in the emergency department, who may not automatically go to using these types of images, which, at minimum, you'd like an AP of the hip and some orthogonal view, which may be, in my preference would always be a cross-table lateral X-ray to best show the directionality of dislocation, and with the cross-table lateral being the anterior aspect of the patient being directly north, and then directly south is the posterior aspect of the patient. And that way we can determine whether the femoral head is out anteriorly or posteriorly. So using these two X-rays are very useful, and it might be best even to have an AP pelvis with cross-table lateral, so that you can see, and it can help gauge whether the acetabular component itself has some irregularity of positioning. In terms of treatments, non-surgical treatment can be considered really only in the instance that we have appropriately positioned and components with appropriate soft tissue tensioning. And as long as that's the case, an attempt at closed reduction with, of course, under sedation and usually in the emergency scenario, with or without the use of hip precautions, either posteriorly or anteriorly, according to the directionality of dislocation, perhaps with a knee immobilizer. We can also add an abduction brace or abduction pillow. And these are ways of treating a implant that has appropriate implant positioning only, with appropriate soft tissue tensioning only. Otherwise, we need to consider operative treatment. And this is really considered in the setting of malpositioning, in the setting of an irreducible dislocation, in the setting of chronic dislocation, where a person may have been out longer than we would have known it. Inadequate soft tissue tensioning, as I've mentioned, excessive implant wear, such as polyethylene wear, resulting in delayed or late dislocations 20 years down the road, 25 years down the road. And then recurrent instability, which may be characterized as at least 2 dislocations or more, and a person is intolerant to the repetitive dislocations, as well as trips to the emergency department and repetitive sedation and repetitive closed reduction procedures. And one way of potentially looking at this is, as we can also classify the unstable hip replacement into these categories that will allow us to guide their treatment. And the categories are listed here, where you can see, first of all, there are 6 categories, the top 2 being component malposition, surgeon error, the third category being deficiency of the abductors, and not something that we necessarily can control unless you're a direct lateral or modified lateral surgeon, where you take down the abductors routinely. Type 4 would be impingement, where we've discussed before, either bony or soft tissue impingement. Type 5 being late wear, such as polyethylene wear or component wear, that now causes loss of soft tissue tensioning and delayed instability. And then type 6 being unresolved, we really don't know. But this is depicted here in table format by the same paper. And what it can show you here is that determining what is wrong will help us determine what needs to be corrected. And simply put, if the acetabular orientation or femoral component orientation is somehow or another outside of what we would hope for optimal limits, well, then, of course, those components would need to be revised. In the third scenario, where there's normal positioning or an appropriate positioning of components, an appropriate no sign of impingement, but there is dysfunction of the abductors, then the use of a constrained bearing surface may be the only option that we have. In the setting of impingement, then, of course, removing the source of impingement, but adding upsizing of the modular head and liner. And we say that because it has been very well demonstrated throughout various studies, not only in the United States, but throughout the world, that the number one cause of failure or complication occurring following a isolated head and liner exchange is dislocation. So we've already seen using an increased femoral head size may reduce the excursion and point of impingement. And because of that, it is always the recommendation to upsize the femoral head and liner, if possible. In the setting of everything looks normal, but there's late wear, then of course the solution is to eliminate the problem by eliminating the polyethylene component that's wearing out. But again, similarly, we need to upsize the femoral head and liner if at all possible. And then, unfortunately, if we cannot really identify what might be going on, we may be left with the option of a constrained liner. And I say unfortunately because it's thought that that's going to, and we know that will increase the forces being placed upon implants and potentially lead to early aseptic loosening of components down the road. So here are some simple examples. This is a pretty obvious retroverted acetabular component, and I depict here in yellow the patient's native anaversion. But unfortunately, the hip replacement that was done in this scenario, which is thankfully not my own, but one that I found online, shows a retroverted acetabular component. And looking at an AP image alone may look like that component is appropriately anteverted because we're looking at a single view, but in truth, that component is retroverted. And because of this, if that hip is dislocating, we absolutely need to revise the acetabular component. If this hip, which I don't have a good pelvic image, but let's just say the implants appear to be appropriately positioned with anteversion of the acetabular component, anteversion of the femoral component, which is not easy to determine using X-rays, but might be more easy to determine using cross-sectional imaging like a CT scan with inclusion all the way down to the knee so that you can compare the rotation of the proximal femur to the transepicondylar axis. Then we may say, okay, well, in this case, we're going to perform a closed reduction. But what if we do that and then find out that the greater trochanter is fractured? Well, unfortunately, that with its attachments, which include the gluteus medius and minimus or hip abductor tendons, we may run into some trouble with recurrent instability in this particular setting. I still think it may be worth trialing a non-operative course following, but this may require some form of trochanteric fixation down the road. In this particular setting, I have a patient who, this is one of my hip replacements, and really went straight forward and without any complication, but unfortunately did go on to develop massive amount of trunnion corrosion at the femoral trunnion, which was quite disappointing. Despite the use of a 32 head, low sort of minimal use of modularity with only +1 head neck length, and then metal on polyethylene bearing. This did turn out to cause significant trunnion corrosion, which then caused severe damage to his abductors. Unfortunately, after revising him, I'll tell you, during surgery, we did encounter that he had some components or some part, at least one half of his hip abductor complex attached. So I felt that it was reasonable to revise him by increasing his femoral head to a 36 millimeter head and liner, which was done here. But unfortunately, about a year later, he started dislocating. Perhaps there was additional and more damage over time to his abductor complex, or maybe it was just waiting to happen that he dislocated and kept dislocating posteriorly, leaving me with really the only option with a well-positioned femoral and acetabular component to constrain him. And since that time, he's fortunately done well without any further complication. And then a patient like this, if this patient were to go on to dislocate with either of the sides, you can see there's significant polyethylene wear by having an eccentric femoral head. And because of this, that may require revision surgery for head and liner exchange, but should require upsizing of the femoral head and head as well as liner. It's important to consider when we're thinking about revision surgery. We've already thought and talked about the reason why increasing the femoral head size may improve hip stability. And while that is true, this is why also people often will discuss the use of a dual mobility bearing surface. I will point out that this is a large Australian registry study showing that the use of a large femoral head when compared to dual mobility bearing really did not have any difference in dislocation rates. And that's an important finding to me because, I think it's also important to understand that it may not be best to really quickly adopt new technologies. For this reason here, we can see that we know for a fact that hip replacements performed either using dual mobility bearing surfaces primarily or in the revision setting may result in intraprosthetic dislocation, where you can see here the inner liner, which is the plastic ball that should be on the around the outside of the ball, has disengaged from this, and that is an intraprosthetic dislocation and eccentricity of the femoral head. But this patient was also found to have corrosion at the metal liner and acetabular component junction, which can be just as devastating as the metallosis that you saw in my own prior patient for trunnion corrosion. And so the point here being that there, as one of my very wise and experienced mentors always said to me, there is no free lunch. It's important to consider that when making any decision during surgery, that each decision we make may have potential pros and cons, and we should know what each of these are. So to conclude, hip replacement dislocation is a very common problem. Unfortunately, one of the leading causes of failure of hip replacements in the United States and certainly throughout the world. Patient factors should be considered that may help guide our intraoperative decision making, as well as planning for our surgeries with regard to things like spinal pelvic parameters. Various strategies really can be taken during our surgeries to mitigate the risk for dislocation, including choice of implant, positioning of implants, soft tissue tensioning, that are all really critical to decide whether or not a person and determine whether a person will dislocate in the future. And a critical evaluation of both patient and surgical factors should always be performed when planning revision for the dislocating hip replacement surgery. With that, I will be happy to answer questions via email, and my email address is listed below. Thank you all for listening and being a part of this talk, and I very much appreciate the opportunity to participate in this conference.